thank you once again for everyone who's joined us. This is the first of 4 presentations we'll be giving this year on child abuse and neglect prevention. Our training series will focus on social determinants of health, human trafficking, and preventing today's topic is preventing sentinel injuries. So we look forward to talking with everyone today, and then hopefully some of you can join us for upcoming webinars or live presentations later this year. Some quick housekeeping announcements before I turn it over to introductions. We have an agenda for today that will include welcome and introductions from Dr. Paul McPherson, who is serving as our medical director on this project. Our main speaker for today is Dr. Jonathan Thackeray, who will give us the medical, clinical, and some of the kind of experience background on sentinel injuries. We're going to be watching our clock. We're scheduled to end at 4 p.m., so time allowing, we'll take a quick break after the first presentation before we move in McPherson and some partner updates from the Ohio AAP, the Ohio Children's Trust Fund, and JFS. We're hoping to provide you with some resources, not just around sentinel injuries, but also on Child Abuse and Neglect Prevention Awareness Month, which is currently occurring in April, and some resources that might relate to the COVID-19 impacts around child abuse and neglect. First, we want to thank everyone who has joined us. First of all of you who are our attendees. Thanks to our partners who are presenting. And then thank you to the Office of Criminal Justice Services and the Ohio Chapter American Academy of Pediatrics for supporting our presentation. You've probably heard this a couple times, but just a quick reminder, we'll be muting all our lines other than speakers as we get started so that we don't have any background noises. And if you have questions, you can use that chat box. We'll take breaks to read those questions and get answers thanks to our moderator. And then we will also keep an eye on questions that if we can't answer during the day, that we will share those with our team and try to get some follow-up for you after this. If time allows, we'll open lines for discussion later in the presentation. This presentation is approved for 3 hours of CME credit through the Ohio AAP. To obtain this CME credit, you'll receive an evaluation link after the presentation today. You can complete that link, and then you will be able to see your PDF of your CME certificate. You can also receive that via email. We do recommend you look at your CME certificates on a computer if possible. When looking at them on a portable device like an iPad or a phone, sometimes they do not appear correctly. So when you get your certificate and the link to complete that, please try to take a look on the computer. If there are still errors, you may let us know. Again, 3 hours of CME, which is transferable to CNE credit and some other medical specialty credits. It is not comparable to social work credit. We'll also be making sure presentation materials and resources are available to our attendees through a link in the follow-up email. So at this time, Dr. McPherson, if you can unmute your line, or I will try to unmute you. And if you'd like to give us any sort of introduction or thoughts.
Thank you, Haley. Thank you,
Perfect.
Haley.
I can hear you.
You can hear me?
Yes.
Fantastic. Well, Haley, thank you so very much. Like she said, my name is Paul McPherson. I'm a child abuse pediatrician with Akron Children's Hospital, and we really want to welcome you and thank you for joining with us today for the first of 4 online regional lectures that we're very happy to present. First and foremost, we hope that your families and yourself are safe and healthy during this pandemic COVID-19 outbreak, and that you and your families remain healthy. And thank you for all the frontline workers that put themselves at risk to care for those individuals that are sick and afflicted with this disease. Haley was kind enough to thank the Ohio AAP. I'd like to thank her as well as Olivia Simon from the Ohio AAP for all the work that they did putting this presentation together, bringing together all of you, the logistics, and making sure the IT is working great. So thank you, Haley and Olivia, for those efforts. As we begin our presentation today, I'd like to introduce to you our first speaker, Dr. Jonathan Thackeray. He is a professor and vice chair of pediatrics at the Wright State University Boonshoft School of Medicine, and he serves as the Chief Medical Officer of Community Health at Dayton Children's Hospital. In his administrative role with Dayton Children's, he's responsible for promoting integration of clinical services and community-based programs to improve access and quality of care for children and families, particularly those adversely affected by social risk. Clinically, he has worked with children with suspected abuse for 15 years. He was the lead investigator for the Ohio Timely Recognition of Abusive Injuries, or TRAIN collaborative. That collaborative was awarded $1 million by then Attorney General Mike DeWine to focus on improving the recognition of and response to minor injuries in young infants. And so with that introduction, we'll move forward, and Dr. Thackeray will begin his presentation.
All right, Dr. Thackeray, I'm going to go ahead and promote you to host so that you can take over and share your slides.
Okay, so Haley, I just want to make sure A, you can hear me, and B, you're seeing the slide.
I see the slides, but I also see the notes at this moment.
Oh, you do? Okay, so let's try this again. Okay, let me try that.
I still see the notes. There you go. I've got just slides now.
Okay, I'm just trying that one more time. Haley?
Yes, so I did have just slides. Now I have the notes again.
Okay, so we're just going to abandon the notes and we'll do this. All right, can you see and can you hear me?
Side.
Okay, excellent. So sorry about that. As Dr. McPherson said, my name is Jonathan Thackeray. I'm a child abuse pediatrician here at Dayton Children's Hospital. And I just want to start by saying a sincere thank you to all of you for taking a few hours this afternoon to listen to a topic that several of us are particularly passionate about. I know for some of you, it's especially difficult to pull yourselves away from what is a busy clinical and administrative time. I'm guessing some of you have pulled yourselves away from helping your children with homeschooling. So whatever the case is, I certainly appreciate you taking the time to meet with us today. I will also echo Dr. McPherson's thank you for Haley and Olivia for putting this together. I want to thank Dr. McPherson and the entire Ohio AAP chapter for making this a priority topic, especially during what is Child Abuse Prevention Month. So the first part of today's webinar, we're going to talk about this concept of infants with trivial injuries and why we should worry and what we should do when we see them. And I will start just by saying that there are no financial relationships that I need to disclose relative to this presentation. So I want to start by having all of you just take a moment and think about these two injuries and ask yourself a question. Which of these two injuries is more severe? So on the left, you've got a 3-month-old baby with bruising of the leg, and on the right, you've got a 2-year-old with a spiral fracture of the femur. And so if you think about it for a moment, which injury is more severe? Is it bruising or is it a broken bone? I think all of us would come to the same conclusion. And here's 2 more pictures. Again, an infant with a bruise on the cheek and an infant with a fracture of the skull. And if I were to ask you which of these 2 injuries is more severe, again, I think we would all be agreed on that. But I'm going to show you those same 2 slides again, and instead of asking you which injury is more severe, I want you to think for a moment about which injury reflects a higher risk for the child. Is it bruising of the 3-month-old baby, or is it a spiral fracture in a 2-year-old toddler? And likewise, for these 2 images, which injury reflects a higher risk for the child? Is it a bruise on the cheek of an infant, or is it an infant with a skull fracture? And we'll come back to this concept of severity versus risk multiple times throughout the course of the afternoon. So my hope for this portion of the webinar is to do 5 things. First, we're going to talk about a physical examination of an infant that really maximizes our opportunities to identify injury. We're going to talk about the concept that morbidity and mortality increases as children experience recurrent abuse in the home. And you'll see lots of case examples of that, and I'll share with you a few studies to support that. Again, we'll talk about this idea of severity versus risk, and if there's nothing else you walk away from in this next hour, I want you to walk away with the idea that the severity of injury to an infant is not the same as the severity of risk to the infant. We'll finish by talking about some of the evidence-based recommendations that exist that should guide the evaluation of an infant with injury. And then last but certainly not least, I want to be able to answer questions that you have. Again, if time doesn't allow to answer them during the webinar or during the break, we will certainly follow up with each and every question after the webinar is complete. So I want to start with this idea of sentinel injuries, and that was the name of this webinar that many of you saw when you registered. And I think most of us are familiar with the term sentinel, which has often been used in the military context going back hundreds and hundreds of years. We talk about a sentinel as a soldier who stands guard or who warns against an oncoming attack. And, you know, again, in this military context, I think most of you probably know that the soldiers who are selected to patrol the Tomb of the Unknown Soldier and serve in that honor, they're known as sentinels. And that's how I think most people have heard of this word sentinel originally. And over the last several decades, really, the term sentinel has been adapted in different large-scale catastrophes and safety events, whether it's airline crashes or nuclear power plant failures. The industry has started to talk about those as sentinel events and opportunities to identify where systems broke down and led to harm of large numbers of people. And then more recently, the healthcare industry has adapted this term of sentinel event. And as you know, we use it to refer to essentially things that have gone wrong, a wrong site surgery, a central line infection that could have been prevented. And we talk about sentinel events as opportunities to go back and look at where individuals or systems broke down that led to harm. And we use those sentinel events as opportunities to prevent future harm. And so that evolving definition is how we landed on this term sentinel injuries. And it was first described by Dr. Lynn Sheets at Children's Hospital of Wisconsin in 2013. And in her study that was published in Pediatrics, she reported on a group of about 400 infants. And what they did was they took infants that they had evaluated for abuse as a multidisciplinary team, and they broke them into 3 groups. One group was children that they had felt definitely were abused after their evaluation, and they they took a group of children where they didn't know if it was abuse or not, and then they took this group of children that they felt there was no concerns for abuse. And when they talked about a sentinel injury, they defined a sentinel injury as an injury that was suspicious for abuse, reported to have been visible to at least one parent before whatever events occurred that led to that child being in the hospital. And so they discarded the children where they weren't sure if it was abuse or not for the purposes of this study, and they just looked at two groups, the ones that were definitely abused and the ones that definitely were not. And what they found was when they looked at the children that they felt were definitely abused, and there were 200 in that group, they found that 80% of those children had had a bruise sometime prior to the admission, 11% had had some type of injury to the mouth prior to admission, and 7% had had a broken bone prior to the admission. And when they looked at the children who had not been abused, and there were 101 of those, they found that not a single child in that non-abused group had any past history of an injury. And so what they found in this group was they found that sentinel injuries occurred in early infancy. 66% of the kids had been injured before they were 3 months of age. Almost all of them had been injured before they hit their 7-month birthday. And I think the most concerning part of this was that medical providers were aware of these sentinel injuries in nearly half of the cases. And I think this mirrors what those of us who do child abuse pediatrics in the state and throughout the country see. When we come in and a child's hospitalized with severe abuse and we start going through the records and we start talking to the parents and we reach out to pediatricians that have cared for this child, it's not uncommon at all that we find that a child who's hospitalized with abuse has some history of a sentinel injury. And again, we'll talk about that quite a bit over the next couple hours. So that was the original definition of sentinel injury that Dr. Sheets put out there, was a visible injury that was seen by at least one caregiver prior to the child being hospitalized. But over the last couple of years, many people who do child abuse research have really thought about sentinel injuries in a much broader capacity. This is a table from Dan Lindberg, who's an emergency medicine doctor and a child abuse researcher out in Denver. And you can see that he proposes, and this group proposed, taking the term sentinel injury far beyond a visible injury. So we're not just talking about a bruise or a burn, but we're talking about injuries we can't see sometimes: broken bones, skull fractures, rib fractures, abdominal trauma. And depending on the age of the child, considering any of these to be a sentinel injury, because really ultimately what we're talking about when we're talking about a child with the first injury is how to prevent that second injury. So you will see me use, you will hear me use the term sentinel injury, trivial injury, first injury, second injury, sort of interchangeably throughout this presentation. But again, we're going to spend most of our time talking about bruises and injuries to the mouth, as it was described in Dr. Sheets' initial study. You will see some examples of these above injuries as well, both in my presentation and in Dr. McPherson's presentation later this afternoon. And I put this figure up here to helpfully explain why we're going to spend our time talking about infants. So it's estimated that 1 in 4 children are exposed to violence over the course of their lifetime. But what this figure shows you is that not all children experience violence equally. And what we see here, and this is Health and Human Services data that's put out every year. This is the most recent data we have. But you can see that children less than a year of age die from maltreatment, and that's all forms of maltreatment, abuse and neglect. They die at a rate that's nearly 4 times as high as children who are 1 to 2 years of age. And you can see every year of that child's life, that rate of death goes down quite significantly. And so the reason we focus on infants when we're talking about these minor injuries, and the reason we're spending so much time talking about infants today, is exactly for this reason. It's because the infants are the ones at a much higher risk of death from maltreatment as opposed to other children. So with that, I will take a quick breath. I have included pictures of nature at scattered portions throughout this presentation. I think this is a really difficult time for all of us as a society. I think this is a really difficult topic to talk about, and I think it's important both for ourselves personally and professionally, and when we do talks like this, to just take a moment and appreciate what is good out there in the world, whether it's children or it's animals or it's nature. I decided to go with nature today, and so you'll see a couple of these throughout. I wish I could give credit to the person that posted this on Twitter. I wasn't thinking about including this when I pulled it off of Twitter and just saved it to my own phone, but I just thought this was a beautiful picture. So, okay. So hopefully that sets the stage for what we're going to talk about over this next hour. I want to start by talking about the physical exam of an infant and how to really maximize your opportunity to identify infants with injury. And before I do that, I'll just have you stop for a moment. It says audience response question. There's no formal way to respond. This is just something for you to think about or talk about within your group at your end of the phone. But think about, what's the approximate frequency of bruising in an infant who can't yet ambulate? 1%, 5%, 10%, 20%. Okay. We talk about bruising a lot for two reasons. One, bruises are the most common type of injury that we see in abused children. And the other is that bruises are the most common type of injury that we see in non-abused children. And I always joke, and any of you that have seen me talk about Sentinel injuries before have seen this picture, but I don't let anybody get through a presentation of mine without seeing pictures of my three boys, Henry and Charlie and Owen. And if you look very closely, you will notice that each of them have little matching forehead bruises. And so we see these in abused kids. We see these in kids like mine who love to run and play and ultimately fall and bump their head. So a question we get asked all the time, and what we have to consider clinically, is how do we distinguish these boys, my boys, from children that have been abused? And there are several different ways and different tools that we have to help us with that. The first is by seeing what the literature tells us about how common bruising is based on the age of the child. And what I've done here is I've compiled 6 studies done over practically the last 30 years, all of them looking at the frequency of bruising in different clinical settings based on the child's age. And the numbers and the specific studies, I don't want you to get too caught up in, but what I want you to see is this trend. First, when you're talking about children who get to be preschool and school age, children that run and jump and play, bruising happens all the time, right? This is not a surprise to anyone who sees patients clinically, who has children of their own. Studies report bruising as frequent as 90% in kids in this age group. But when you start to go to the younger kids and you look at our 6 to 12-month-old kids, these kids who are starting to cruise, maybe starting to ambulate, you can see that the numbers drop pretty significantly, but are still, not uncommon. We see frequencies of 6.4%, 10.6%, 12.4%. But when you look at studies that look at those infants who are 0 to 6 months of age, the numbers drop pretty dramatically. And now we're talking about studies reporting prevalence of 0.5%, 1%, 1.3% at best. So when we see infants 0 to 6 months of age who have bruising, we have to recognize that it is not common. It is rare. Doesn't mean it's abuse, but it should prompt us to evaluate that infant further to figure out what might be going on with him or her. Another way to help us distinguish accidental from abusive bruising, and it goes hand in hand with age, is based on the developmental stage of the child. So there were 2 studies done, again, quite a while ago. There's been others that have the same findings. Naomi Sugar did one in '99. Dr. Carpenter, Jim Carpenter did one in the same year. Sugar's study looked at children presenting to a primary care setting where they had no concerns for abuse. Carpenter's study looked at children either in the primary care setting or who were coming in for hearing testing. And they used slightly different developmental milestones. One used children who could crawl versus sit versus ambulate. The other used different milestones. But when you line them up next to each other, you can see that their data is pretty similar. So stage 3 on the right, those are your children who can pull to a stand, who can ambulate. Children in the middle in stage 2 are children who can crawl, children who can sit up. And those stage 1 children are children who essentially are your youngest infants, right? You're 0 to 6 months old, not yet starting to meet those developmental milestones. And so again, when we see infants at the very early stages of development who have bruising, it's not that it never happens, but it happens much less commonly than children who are more advanced developmentally. And so we have to ask ourselves in this stage 1, this early stage of development, what else could be going on with this child? Another tool that we have at our disposal is what we know about where bruising is on the body. And so what the literature tells us and what we see clinically and anecdotally is that the bony parts of the body that stick out are less concerning for those kids who are able to ambulate and walk around, right? So a child's walking around, they fall down and hit their knee, we expect a bruise. We expect a bruise on their shin. We expect bruises on their forehead like my boys. We might expect a bruise on the chin where they fall and hit their chin against the ground. But where we start to really get concerned is when we see it in other areas, those areas that don't have bony protuberances, the torso, right? So the back, the chest, the abdomen, the neck, any soft tissues areas of the body, the soft tissue of the arms, the legs, the genitals, the buttocks. And then anytime we have pattern bruising, that's certainly concerning. And that's for ambulatory infants or toddlers or even school-age children. But when we're talking about infants who don't yet ambulate, a bruise anywhere on the body is concerning. A bruise on the knee, a bruise on the forehead for a child who can't yet pull themselves up to a stand and walk, a bruise anywhere on the body is concerning. For those of you who are into mnemonics, Mary Clyde Pierce is an incredible emergency medicine physician at Lurie Children's Hospital in Chicago. She and her group have published a lot of research on bruising and when we should be concerned and when we shouldn't be. And her group has coined this mnemonic of 10-4 faces P. And the 10-4 in the ACE are what we just talked about. It's bruising to the torso, the ears, the neck, the angle of the jaw, the cheek, or the eyelid. And the 4 refers to any bruising of the torso, the ears, or the neck in a child who's less than 4 years of age, or it refers to any bruising in a child less than or equal to 4 months of age. She, in addition to what we've been talking about with bruising, added in these other areas of concern. F is for frenula, S is for sclera, and P is for patterned injury. So 10-4 faces P is a nice mnemonic to help you remember when to be concerned for abuse in a child, any young child broadly. They have studies showing that this mnemonic has about a 96% sensitivity in detecting abuse. So it's not just a clever way to remember it, but it's actually a very useful clinical tool as well. And we've talked some about bruising. I'll just show you examples. This is an injury to the frenula, and we'll look at several case examples of this over the course of the afternoon. This is an injury to the sclera, just a hemorrhage. And again, these are not significant injuries. These are relatively minor injuries that could easily go undetected. And when I'm talking to anyone about maximizing opportunities to identify injury, the rule I want you to remember is if you don't look for injury, you're less likely to find injury. If you don't pull down the diaper of this child in the top left, you're going to miss this linear pattern of bruising at the gluteal cleft that indicates this child's buttocks have been struck with an object. There's nothing else that causes this pattern of bruising. If you don't pull up this child's hairline in the upper right corner, you would miss what is collections of blood from vigorous hair pulling from the child's mother, which is the preferred form of punishment. So lots of violent traction on the scalp causes collections of blood in the subgaleal space, and this is what it looks like. But if that child had long hair coming down over her shoulders, you might not notice it necessarily. This child at the bottom has relatively minor injury. It's petechiae, tiny pinpoint bruising to the posterior aspect of the ear. And if you looked at this child from the front, you looked at the front of the ear, you wouldn't see anything. When you look at this aspect, you can see the petite eye, and that indicates to us that there's been some trauma to this child's ear, whether it's a direct blow to the ear, a pinch to the ear, or something else. So we, every chance we get, advocate that when you have the opportunity to examine an infant in any clinical context, that you take the opportunity to undress that infant head to toe. Paul had mentioned our TRAIN collaborative study that we've been doing throughout Ohio for the last several years. What we found, going back to 2015, children who come into our primary care practices, children who come into the emergency department, it was rare that they were getting full physical exams. I mean, if a child came in with ear complaints, the physician would look at the ear, maybe listen to the heart and lungs, but rarely, if ever, would children get undressed. And there's lots of reasons for that. And we've spent a lot of time working with providers to try and break down those barriers. But if you don't look for injury, you're going to miss it, and there's really no way around that. Okay, so with that, I will share with you a picture from Instagram. This is the shore of Lake Erie, and I thought it was gorgeous. And for those of you from the Cleveland area or with an interest in Cleveland who happen to also be on Instagram, I highly recommend you follow this individual in the 216. There are hundreds of gorgeous photos of Cleveland and the surrounding area on that Instagram page. So if you're a Cleveland fan, I highly recommend checking him or her out. All right. So the second thing I wanted to talk about is this idea that morbidity and mortality often increases with recurrent episodes of child physical abuse. And I think some of us fall into a trap sometimes that we think about child abuse as something that can happen to anyone. It can happen in any home. And often when it happens, it's an otherwise normal, non-stressed caregiver that just in a moment of frustration, whether the child's crying or the child's made a mess or the child got sick, whatever it is, within that moment of frustration, the caregiver snaps and harms the child, but had never harmed the child before that, will never harm the child after that. And I think what we see more and more is that the reality is that many children, when they're exposed to harm in their home or in their living environment, they're not just exposed to harm one time. They are actually repeatedly exposed to harm. And we need to be cognizant that as they experience more and more harm, the chances that harm and that abuse escalates is real and something we need to be mindful of. I'll share with you a couple studies and a couple clinical examples to drive home that point. This is a study that we did, a group of us in 2014, and we looked at data from a pediatric accountable care organization. So there were thousands and thousands of children in this database. And we looked for children that had suspected abuse, and we determined that they had suspected abuse either because they had a skeletal survey done or because there was a diagnosis made of some form of abuse. And throughout this accountable care organization, we found that there were 1,361 children who had suspected abuse. 26% of those kids had a second abuse event or more within a year, and 40% of those children had an abuse event within the following 2 years. And when we looked at those children who had one or more recurrent events, so a second or third or fourth event of abuse, what we found as risk factors were, one, children from rural environments, which I know much of the state obviously is. It included children who were younger age, which we defined as less than 30 months. And interestingly, I think for this discussion, it included children who had few injuries, so one or two, and it included children who had minor injuries, which we defined as dislocation, open wound, or superficial injury. So basically, if you were a child with an abusive event and you had few injuries or you had minor injuries, you were more likely to suffer a subsequent event down the road. And I think that that speaks to sort of our system-wide response. Maybe we have a bias, or the child welfare system had a bias, that when kids have relatively few injuries, relatively minor injuries, Maybe the response doesn't need to be as significant as kids who are clearly abused with multiple injuries, abusive head trauma, that type of thing. I'll share with you a couple cases that I've seen and that colleagues have seen. These are all 3 kids who were in the hospital for evaluation. This child was in for bruising of the arms, bruising of the side of the torso. And when we did the recommended x-rays, we found that this 4-month-old female had multiple healing rib fractures. And when we talked to the caregiver about this child and how she'd ended up in the hospital and asked about past injury, Mom described this baby as an easy bruiser, and in fact had noted that the child had had 3 or 4 nosebleeds over the last 2 weeks. A second case, a 5-month-old male came into our hospital, and you can see this boy has bruising of the cheek, has bruising of the leg down by the diaper area. And when we talked to this mom, and we did the x-rays to evaluate for fracture, and this child had a classic metaphyseal lesion of the leg, or a bucket handle fracture, a corner fracture of the leg, as well as a healing rib fracture. And when we talked to this caregiver, Mom had said that the baby had multiple bruises on the forehead several months ago. And this mom reported, we couldn't verify this, but she reported calling the pediatrician. The pediatrician basically said, you know, if the bruises resolve, no need to come in, nothing to do. And if they recur, then bring him in and we can evaluate further. The third child was a child that was put in the intensive care unit for an injury I'll show you in just a moment, but incidentally had bruising of the angle of the jaw on both sides. The injury that had put her in the ICU was a significant burn to the lower leg. And you can see just the edge of the burn there along with the wound vac applied to it to try and promote healing. Unfortunately, this child ended up having her leg amputated because of the severity of the burn. But when we talked to this caregiver about how they had ended up in the hospital and if there was any past injury, the caregivers had said that this child had been seen by the pediatrician 1 month prior, and at that time had bruising of the buttocks and bruising of the leg. And so, you know, those are 3 cases, all children who ended up in the hospital with pretty severe injury, you know, a burn requiring amputation, multiple fractures, multiple bruises, each of whom had some minor injury weeks or months prior to that hospital admission. And again, I think I told you, those of us who do child abuse work day in and day out, we see this pattern over and over again. By the time we come to see the child in the hospital, we often find that there's some past history just like this in the chart. And so if we can intervene here when the child has bruising or when the child has nosebleeds, hopefully we can prevent the much more severe injury from happening. I'll share with you just a couple studies. I don't have too many studies included in this, but I did want to just share this with you so that you see that this is a phenomenon. It's not a new phenomenon. It's been reported, you know, for decades now. Carol Jenny in 1999 published a great article in JAMA. It's one of the key articles in our field of child abuse. But they looked at kids with abusive head injury that came through their hospital system and were missed the first time they came through. And they found that about 1/3 of children who were diagnosed with abusive head trauma were actually misdiagnosed the first time they came through the hospital. And at least 4 children, and maybe 5, depending on how you interpret the data, died what would have been preventable deaths if they'd have been diagnosed correctly the first time they came through the hospital. Schmidt, years before that, and their group studied abused children, where a report of abuse was made and the child was returned to the home in which the abuse occurred, and there wasn't any intervention, there wasn't a safety plan in place. And they found that those children who went back to that home where the abuse had occurred had an increased risk of recurrent abuse by 35 to 50%, and a higher risk of being killed from abuse by 5 to 10%. One of the biggest studies done was done by Dr. Putnam Hornstein and her team out in California in 2011. They looked at over 4 million children in the state of California, and they looked at children who had basically any non-fatal allegation of maltreatment. So if a child was reported for being maltreated and was alive, they went into this database. And they found that if you were a child in California and you had a prior allegation of maltreatment, you died from intentional injuries from abuse at a rate that was nearly 6 times greater than children that had never been reported to child welfare. Interestingly, they also found that children who had been reported for abuse at least once died from accidental injuries at a rate that was twice the rate of unreported children. So again, it's this concept that children who are raised in environments with harm, they are repeatedly exposed to harm. It's not often a one-time event. Kate Deans is a surgeon at Nationwide Children's. She did a data analysis of the Ohio Trauma Registry database. So this is our own data here in Ohio. And there's lots of numbers here. What I want you to pay attention to is this last row, the mortality rate. In the Ohio Trauma database, if you had a single episode of NAT, non-accidental trauma abuse, the mortality rate is 9.9%. But if you were a child that had 2 or more episodes of abuse, your mortality rate went up to almost 25%. So a really significant jump in mortality from multiple episodes of abuse. And so there is a need for us to get it right the first time, right? If we don't recognize that a simple bruise on the cheek or a small tear to the mouth is abuse, or at least concerning for abuse, then the child is going to go back to that same environment. And abuse is different from other forms of trauma. It's not like motor vehicle accidents. It's not like, it's its own type of trauma, because it's likely to continue, it's likely to escalate, it's going to lead to physical and psychological morbidity, and it may result in death, and it often does. And so the effects of recurrent abuse on these children are cumulative, whether it's physical or emotional, but the effects last for a lifetime. And so we, as healthcare providers and as people involved in the healthcare system, really need to identify these injuries early and prevent them from becoming worse. All right, I'm going to stop here on this picture of Seattle. Sigma Sridharan is the photographer. I loved this. I especially love this photo because my parents live in Seattle and I can almost see their window from this photo. Haley, are there questions that we need to address at this moment, or should we keep going?
Hi, Dr. Thackeray. It's actually Olivia from Ohio AAP. We did have one question pop up. They were curious if there is a link between Sentinel physical abuse findings in children with sexual abuse also. Is there a link between the two?
I'm sorry, Olivia, can you I just want to make sure I heard that question correctly. Yeah, I think I did. Can you repeat it?
Sure. If there are studies that link Sentinel physical abuse with children with sexual abuse?
That's a great question. So I'm not aware of studies that link these particular, more trivial injuries or sentinel injuries of physical abuse with sexual abuse. There are several studies out there that that identify connections between different forms of abuse. So if one type of abuse is occurring in the home, there's a higher likelihood that other types of abuse could occur as well, both for different types of child abuse as well as domestic violence, certainly. I'm not aware of any studies that particularly link these minor injuries to other forms of violence, but we do know that when you see one type of violence occurring in the home, you certainly have to assess for others. And so anytime, I'm evaluating a child with a concern for child abuse, we certainly have an eye towards other forms of violence, and we're always asking about domestic violence in the home. But that's an excellent question.
Great. Thanks so much. And I also just wanted to send another reminder for anybody that maybe joined late, just to make sure that your microphone is muted. And that's all.
Okay.
Now for me.
Okay, thanks. All right. So next, I want to go back to this idea about severity of injury and severity of risk, and make sure I'm driving the point home that they are not the same thing. So we looked at these pictures at the very beginning of the presentation, right? You've got bruising of a 3-month-old baby. You've got a spiral fracture of a 2-year-old toddler. And I think if we had a chance to poll everybody, I think all of you would have said that the fracture is clearly the much more severe injury. I mean, it's a broken bone versus a bruise. But where I think we get into trouble is we equate that as the spiral fracture is much riskier for the baby than the bruising, and that's just not the case. Likewise, these are the other 2 pictures we looked at. A skull fracture is clearly a much more severe injury than a bruise. But when we talk about risk to the child, I'm much more worried about a bruise to a young infant than I am, you know, a child who's pulled to a stand and fallen and hit in the floor and has a skull fracture. If you go back to this slide, I'm much more worried about a 3-month-old who can't pull to a stand, who can't ambulate, who has significant bruising on the leg, which to me looks like somebody's forcefully grabbed this leg, you know, multiple times. That carries a much higher risk for this baby than, you know, what we think of as sort of a classic toddler's fracture. Come back to that in just a second. I want you to again, no formal way to respond, but I want you to think to yourself, what do you think is the most common physical exam finding before a child has a fatal or near fatal abuse? Is it injury to the mouth? Is it swelling or injury to an extremity? Is it bruising? Or is it altered mental status? And by now, you are probably going to guess that it is a bruise, and it is, in fact, a bruise. Again, Mary Clyde Pierce, and I'll acknowledge her formally at the end of this presentation, but she and I developed this presentation and gave a version of it at the AAP's National Conference and Exhibition a couple years ago. So you'll see lots of work from her, but she's done a lot of excellent research in this field. This is a study that she and her group put out in 2017, and they looked at cases of fatal or near fatal physical child abuse, and they had 20 cases of young children in their study. And what they found was that 90% of kids had bruising either before or at the time of their presentation for their fatal or near fatal abusive event. 2 out of 3 kids, 64%, had prior unexplained bruising. So this is bruising that was seen, but no action was taken. And depending on the case, the bruising was seen by a doctor or a social worker or a police officer within days to weeks of the fatal or near fatal event. And all of the kids suffered subsequent traumatic brain injury, which resulted in 4 deaths. The ones who had prior unexplained bruising. And I like this study, again, because it drives home the point that even though it's just a bruise, and I put that in quotes, just a bruise, we really need to be concerned about why that bruising is there. And I think it emphasizes the point that abuse escalates over time. So what starts as a bruise last week or last month turns into abusive head trauma, often results in death. The other thing I like about this study is it drives home the multidisciplinary nature of what we do. So there are lots of people who are involved with children every day, whether it's child care providers, educators, home visitors, law enforcement, social work, behavioral health providers. There's an opportunity to share this education much more broadly than with pediatricians. Child welfare professionals, we've spent a lot of time working with them. I think it's important that everyone who interacts with children understand these concepts so that we all have a shared concern when we see an infant with, you know, again, just a bruise. It would be ideal that we all have the same response, whether I'm a pediatrician or a home visitor or a child welfare professional going out and doing a home visit. I'll share with you a couple cases, again, just to highlight this idea that severity of risk or severity and risk are not the same thing. This is a young girl that was seen at my hospital probably going back 15 years ago now, if not longer. She came in to the emergency department with a little bit of fever and was noticed to have this lesion on the mouth. And she was evaluated by the pediatrician, by the ear, nose, and throat specialist, by the infectious disease specialist. And because she had a little bit of a fever, the initial diagnosis was that maybe this child had some type of focal strep or staph infection in the mouth. Perhaps it was a herpes blister, perhaps it was Coxsackie virus. Weren't really sure, what infectious agent it was, but the decision was made to put her on multiple antibiotics, antivirals, and admit to the hospital. And that's what happened. And sure enough, over the course of 2 or 3 days, this lesion continued to get better and healed up. And so she was sent home on an outpatient regimen. I don't remember what it was, but it was some type of antiviral antibiotic. And she was sent home, and nobody really thought about this case again until 2 weeks later. She returned with altered mental status and seizure activity. And now her physical exam was much different. She had bruising of the torso, she had bruising of the neck, she had bruising of the upper arm, she had some subtle bruising behind her left ear. And because she had altered mental status, because she was having seizure activity, she underwent imaging of the head. And you can see all of the areas that are bright white there, immediately overlying the brain, are bleeding as the result of an abusive head trauma. When we went back and delved more into this case from a psychosocial standpoint, we learned that there had been extensive domestic violence in the home, and that a step-sibling had actually been removed from this home a month or two earlier because of a broken bone at a very young age. But we just didn't have the idea of abuse on our radar from the very beginning, so those weren't the types of questions that we had asked early on, unfortunately. This is a baby, an 8-week-old male. So I was talking to colleagues about this idea of sentinel injuries. This is several years ago now. And after my presentation, one of my colleagues came up to me and said, "Hey, I want to show you a picture." And he had taken a picture of this baby. This baby was born premature and had come into the bronchopulmonary dysplasia follow-up clinic for follow-up of lung disease. And when they did the physical exam, they noticed these 2 bruises on the left cheek. And when they asked Mom about it, Mom said, I don't know where they came from. I put him to bed. He had this pacifier in his mouth, which you can see there. And when he woke up, he was laying on the pacifier and he had that bruising. So the team that evaluated this child at that BPD clinic felt that was a reasonable history, sent the child on his way. And it happened to be we were talking about these types of injuries just a week later, 8-9 days later. And again, they were concerned enough to take this picture, but there was no further action taken, no testing, no reporting. They thought the history was legitimate and sent this child home. So we looked at this picture and we talked about the case, and we recommended, this is a child that really needs to come in and get a full abuse workup. And so they called the child, the mother at home, brought the child in, and mother said, "It's funny you called because I just noticed overnight that he had stopped moving his leg, and he seems to be in pain." And what you can see there pretty clearly is a fracture of the distal tibia. And we know based on the appearance of that fracture that it wasn't there when we saw the child here for the BPD clinic visit. It was sustained at some point after that visit. Haley, I just want to make sure you can still see my slides.
Yes. Yep. I've still got you
Okay.
right at the returns 11 days later.
Okay. Excellent. Sorry, I just had to plug in my computer and it switched screens, so I wanted to make sure.
No problem.
This case, I showed you this picture earlier when we were talking about injury to the frenula. This is a 3-month-old male who came into the emergency department with a history of bleeding from the mouth. And when the physician did the exam, found this lesion, and actually reported this to Children's Services because it was an unexplained injury. Did not do any other testing in the emergency department setting. There were no x-rays, no other testing for injury, but it was reported. And so I want you to just imagine for a moment that you are on the receiving end as a Children's Services employee, and somebody calls you and says, well, I've got this 3-month-old male, and he's got an injury to the mouth, and they ask you to describe the injury, and you say, well, it's like literally the size of a pencil tip on the upper lip, and there's just a tiny bit of blood there. And I don't know if or how that played into the decision-making for Children's Services, but what happened with this case is essentially nothing. They said, okay, we'll follow up with this patient, at some point after you've discharged them home, and that was the plan. But unfortunately, this child came back 4 days later, now with seizure activity and was unresponsive. And again, you can see had injury to multiple areas of the brain, as well as a fracture of the skull, a classic metaphyseal lesion or a bucket handle fracture, a corner fracture of the distal tibia, as well as a healing rib fracture. And the healing rib fracture, I think, is important because it's healing. I suspect it might have been present on this day, 4 days previous, when we saw this child with the injury to the mouth. And if we had done the testing on this day and found that there was a rib fracture there, I wonder if and how the Children's Services response would have been different if instead of just saying we have this tiny little lesion to the mouth, if we could say there's injury to the mouth as well as a fractured rib. And we'll never know. But I do wonder with cases like that if it would influence the Children's Services response. So you've seen a couple studies, you've seen a couple examples, but the bottom line with this is that when we equate how severe an injury is with the severity of the risk to the child, that is flawed reasoning. And that flawed reasoning increases the possibility of harm to the child. When we see a baby with just a bruise, and we say that to ourselves, it's just a bruise, we are sending that child back into an environment where they are at significant risk for escalating harm. Said another way, the size of the injury doesn't measure the size of the risk. And that's a really tough concept for us as pediatricians to wrap our head around, for our colleagues in child welfare, for our colleagues, we as pediatricians and child abuse pediatricians do this work all the time, and for us it's a tough concept to wrap our heads around. But imagine our emergency medicine colleagues. We know that more than half of babies who go to hospitals with injury don't come to children's hospitals. And so now you're talking about, adult emergency medicine providers who don't see children near as much as we do. And so they're at risk for seeing a baby with just a bruise and thinking, oh, this is just a bruise. But that is again, flawed reasoning, and it puts these kids at risk for harm. This is my sort of light at the end of the tunnel slide. A, I think it's just a beautiful picture, but B, I like it when we're talking about sort of ending with notes of optimism and hope. So these errors do result in harm to patients, but the good news in all of this is it's preventable. There are evidence-based tools. Use of a standardized approach to patient assessments can greatly reduce the risk of harm to these infants, and that's what we're going to spend the last portion of this talking about. Olivia, are there questions?
I know there's a question in the chat about, what we can do to raise awareness right now when we're all social distancing. And I think that is going to be addressed later. So we'll kind of, I did see that, but we'll kind of, I guess, hold that until this presentation is done.
Okay, excellent. Yeah, that's an excellent question, and we will get to that throughout the afternoon. Okay. So finally, I want to talk about the evidence-based recommendations that exist and how to appropriately evaluate an infant who has injury. So I want you to think again for a second to yourself about this question. So if you have a 3-month-old who comes in with a bruise of the thigh, which of these, all of the following are indicated except which one? Skeletal survey, screening for injury to the liver, screening the child's blood for some type of bleeding diathesis, a psychosocial assessment of the child, or looking at factor levels. We'll come back to that. So if you're not familiar with the AAP's clinical report on the evaluation of suspected child physical abuse, would highly recommend it. We'll make sure it's included in what we send to you in follow-up. But basically, it goes through different categories of injury for children, and it talks about what laboratory testing is recommended, what radiographic testing is recommended, and then there's some comments there about each of the different categories of injury. And so when we talk about children, and this is more broadly than infants, but young children who have fractures, you can see there's a whole host of laboratory testing we do. We look at calcium and phosphorus. We think about vitamin D levels and parathyroid hormone levels in rare cases, and we think about much less common medical conditions that could cause bone fragility, and we think about doing copper and ceruloplasmin levels. In very rare cases, we think about testing, whether it's skin biopsy or now, more recently, genetic testing for different forms of osteogenesis imperfecta and other bone fragility conditions, as well as doing a skeletal survey. So when we see one fracture, we want to look at all the bones and look for fractures elsewhere. But you can see, I think it's interesting, a lot of this testing really isn't about finding injury. It's about looking for medical conditions that could predispose a child to injury. And so as much as we talk about injury and concerns for abuse and finding additional injuries when we find the first injury, we do always want to keep a mind towards considering a differential diagnosis and thinking about what medical conditions could be causing this child's injuries or could be mimicking this child's injuries. When we think about bruises, again, there's a whole list of tests, CBC, platelets, PT, INR, PTT, von Willebrand's testing, factor testing, as well as our skeletal survey and brain imaging for infants with suspicious bruising. When we have abdominal trauma, we have liver tests we do. We screen for pancreatic trauma. In certain cases, we image the abdomen, always thinking about a skeletal survey for our children less than 2. And then children with head trauma, there's a whole differential that we consider, but it includes bleeding disorders, metabolic disorders, and we do pretty aggressive imaging and screening for these kids. So a lot of this workup is to look for additional injury. A lot of it is to rule out medical conditions that could be either mimicking or predisposing the child to injury. But I just want you to be aware that these guidelines are out there and they exist, and the literature continues to update. It's been 4 years now, and so there are continually updated recommendations. But I think this is a good starting document when you're thinking about children with injury in your clinical practice. When we talk about young infants, so going back to our infants less than 6 months of age with injury, and really any kind of injury, what we suggest is a standardized approach. So again, that full head-to-toe examination. If you see a bruise on the ear, you absolutely must undress that child head to toe and look for injuries elsewhere on the body. A head CT for our younger infants, a skeletal survey, AST, ALT, lipase, a psychosocial assessment to screen for issues in the home, including mental health issues with the caregivers, substance use issues with the caregivers, domestic violence, past law enforcement, past children's services history. And there's more. So to go back to that question that I asked you a couple slides ago, that infant with a bruise gets all of those tests. We do the bleeding workup to consider hematologic disorders. We do the skeletal survey to evaluate for fractures. We do a head CT because we know that a number of young babies will have a occult head injury that isn't clinically obvious. We find that a number of babies have some type of intracranial bleeding when we don't expect it clinically. And the psychosocial assessment is critical for these kids. So it seems like a lot, and we'll talk about that in just a little bit. It is a lot. It is a lot of testing, and that poses its own issues, which again we'll talk about soon. But my other piece of advice is, if you have an infant with an injury of any kind, it never is wrong to call a child abuse pediatrician. And I can speak confidently on behalf of the 6 children's hospitals and the Ohio Children's Hospital Association. We have made ourselves available to any and everyone in the state. When you see a child in your clinic this afternoon and you're worried about an injury, call one of us. Call the children's hospital nearest to your practice, and we will help guide you through these cases. They are tricky and they are nuanced, and every one of them is different in their own way. And so we recognize that, and we are more than willing to help at any time. So rather than trying to memorize the workup for a child with any specific injury, feel free to call us and we will help guide you through all of that. Again, it's a lot of workup, and there is certainly no disputing that. But the reality is that the workup is there and it's recommended because there is an evidence base to support it. And I've just pulled 1 or 2 studies here to share with you because I think the results are pretty dramatic. This was a study that was done collecting data from child abuse teams across the country, 20 teams in total. And there were almost 3,000 children enrolled into this data set. And what this group did was they looked at infants who were less than 6 months of age who had isolated bruising, so bruising and nothing else, who underwent some diagnostic testing for other injuries. So a skeletal survey, the neuroimaging that we talked about, they looked at just those kids. So these kids we've been talking about for the last hour or so. They looked at those kids, and they looked at how often those kids with nothing but bruising, visibly, had some other injuries. And this is their data, and again, lots of numbers here, and I don't want you to focus too much on the specific numbers, but I want you to look over here in this column. There were 146 children who had isolated bruising and nothing else. And what they found was that skeletal survey, when it was done, identified 1 or more injuries in 23% of those kids. Neuroimaging identified new injury in 27% of those kids. And abdominal injury, when they did a CT or liver screening, liver enzyme screening, they found abdominal injury in 2.7% of those kids. And so overall, in this study, and again, it's from 20 teams across the country, but if you were a baby less than 6 months of age and all you had was a bruise or multiple bruises, 50% of those infants had at least 1 additional serious injury. So it seems like a lot of testing, and it is a lot of testing, and there are issues that go along with that. But the recommendations are there because we know when we look, we will often find additional serious injury. Another study that we were a part of and grew out of this TRAIN collaborative that we've talked about a couple times was the lead author was Emily Eisman down at Cincinnati Children's Hospital. And what they did was they looked at infants who were less than 6 months of age who presented to their emergency department or their urgent care setting with a visible injury. And first of all, they found that nearly half of infants with an injury didn't receive a skeletal survey. So we shared those AAP recommendations for what you should do when you suspect child abuse. And without a doubt, it is a clear recommendation that when you have a baby with an injury, you should do a skeletal survey. And we would assume, and we did assume going into this collaborative across the state that, as children's hospitals, as child abuse pediatrician teams, we do the recommendations all the time, right? If we see infants, we of course get a skeletal survey. Turns out that wasn't the case. Our experience mirrored exactly what you see there. A third of kids, half of kids, 2/3 of kids, babies with injury were not getting skeletal survey, even though it's like the clearest tool in our toolbox that has the strongest evidence to support its use. We as children's hospitals and as child abuse pediatrician teams, as hospitals who had child abuse pediatrician teams, were not getting this workup done. So that was significant to us. But the other thing that they found in this data is that children who did get a skeletal survey, they found fractures when they weren't expecting it for, again, these most minor of injuries. An isolated abrasion or a laceration. 14% of those kids with an isolated abrasion or a laceration had at least one fracture that wasn't expected. If you were a baby with an isolated scalp hematoma or swelling, 13% of them had fractures. If you were a baby with just a subconjunctival hemorrhage, 33% of those babies had occult fractures. Now, these are small n's, right? These are not large numbers of kids, but it shows you that even the most trivial of injuries, a subconjunctival hemorrhage, it's not unheard of that babies with that and nothing else visibly have fractures. This data shows it. So when we do the workup, we will find additional injury. So I want you to just think to yourself for a moment. So we have all these recommendations and we have evidence to support them. And when we do the recommended workup, we find additional injury. Why might these recommendations not be followed? And I'll share with you a couple thoughts on what we've observed from doing this work around the state. One, we hear providers all the time say, this is unnecessary medical testing, or this is expensive, it's a burden on healthcare. All the time we are hearing about ways to improve efficiency of care and quality of care and reduce the cost of care. Why are we doing all these tests on these children? And one, I think we just, hopefully I just convinced you that when we do the workup, we find additional injury. So there's that aspect of it. But the other article, and again, we'll share this with the group in follow-up. It was just published this month in Hospital Pediatrics. It's an opinion piece, and it's called Pushing Back, Balancing the Cost Against the Price of Missing Child Physical Abuse. And they talk about their approach and their hospital system to really fight this perspective that we shouldn't be doing the testing because it's either unnecessary or it's costly. And what they say in the article, and it really is great. It's 2 or 3 pages. It's well written. They talk about a particular case study of a young baby who had a missed injury, came back with abusive head trauma, and they talk about the cost of that child's workup when she came in with the bruise and what that would have cost versus what the cost to the healthcare system now is now that she's a victim of abusive head trauma, G-tube dependent, ventilator dependent, chronic care, for years and years. And so they compare the two impacts of cost for that one patient. And I love this quote from the article. They said, cost must be balanced against the price of missing abuse. That is, what is the impact on a child's life if a critical misstep in diagnostic evaluation allows abuse to evade detection? So I certainly understand the cost issue. We have for years tried to advocate for different methods of payment in the state. I think most of you know if you're a child who experiences sexual abuse or there's a concern for sexual abuse, that evaluation in large part is paid from a fund from the Ohio Attorney General. But if you're the same child and you come in with a concern for physical abuse, there is no fund to pay for that. So it does result in claims to insurance. It results in charges to families who are self-pay, families who can least afford to cover the economic burden of the workup. So it certainly is a legitimate concern. And I would just encourage all of you to advocate for changes in the payment system so that families who need this workup aren't getting unnecessarily burdened by it. But again, the evaluation does yield results, and you know, if we're looking at cost only, the cost of evaluating a child now is certainly much less than the cost of treating a child who's been the victim of abuse down the road. The other thing that, the other category of things that we hear often are these types of comments. It's a nice family. I know this family. This family comes from my neighborhood. I don't want to cause this family stress. They're telling me the truth. I can just sense it. I took care of the mother when she was a child. She would never do this to her baby. We hear this quite often, and it's a significant barrier to why evaluations aren't completed, and one we constantly have to be mindful of within ourselves and address with our colleagues. And it's this issue of bias. Bias exists. There is no doubt. You see it in other clinical decision-making initiatives throughout medicine. We see it often in child abuse. I referenced the study by Carol Jenny done in JAMA back in 1999, and I told you that about a third of kids with abusive head trauma were misdiagnosed the first time they came through the hospital. Well, it turns out it wasn't all kids that were misdiagnosed. The kids that were misdiagnosed turned out to be the white children and the children who came from dual parent homes. So if you were African American or if you were a child of just mom, abuse was higher on people's radar, and they were more likely to catch abuse the first time you came through. Other studies have been done, and I've referenced them here. Wendy Lane out of Baltimore did a study in 2002 that showed that minority children were evaluated for abuse more often, and they were more likely to be reported for suspected abuse. Dr. Lane, Dr. Lasky, who's out in Utah now, have done studies showing that we consider physical abuse more often in children from lower socioeconomic status than we do from children of higher SES. And we know that there are risk factors for abuse, right? Financial stress, job stress, mental health, substance abuse conditions in the home. There are definitely risk factors. But another reason to advocate for standardizing this approach to injury is to take that issue of bias out of it. You know, I think we all know of an individual in our lives, whether it's personal or professional, who's done something wrong that shocked us, right? You never would have guessed that my colleague would have done this or this or this. Colleagues that are charged with crimes, family members, friends that are charged with crimes. We just don't know, right? And if we standardize the approach to infants with injuries, then we don't have to know. It doesn't matter if you're from my neighborhood or if you're from, 10 miles away. I'm going to evaluate your child the same way, no matter where they come from, no matter what they look like, no matter what the background is, because we just don't know. And we don't want bias to influence when we're doing our testing. Okay. So with that, I will wrap up with just a couple quick final thoughts. Number one, children are at risk for falling through the cracks. We see that in all walks of medicine and policy and society. But when we're talking about injury, kids, and especially our youngest kids who are at the highest risk of death, are at risk for falling through the cracks. And it's because we don't recognize that an injury implies significant risk. We don't act appropriately when we do see an injury. We don't understand the science and the literature. We fall into that trap of severity of injury being the same as risk, and we underestimate the significance of something as simple as a bruise on the cheek. And we come into our clinical interactions with assumptions and with bias that we need to leave at the door if we're going to maximize safety for these kids. Second, if I can give you just 4 critical but simple actions to make a difference in your care. Number one, examine your infant's head to toe. I don't care why they're coming to see you, what the context is. Undress that infant head to toe, because if you don't look for the injury, you're not going to find the injury. Take the history without teaching it. We didn't talk a lot about history for injury throughout this presentation, but what I find, or what we find, those of us who do this work, is that pediatricians are often well-meaning in going through a history with a family, but inadvertently will give the family opportunities to make up a history that wasn't true otherwise. So instead of saying, if you have a baby with a bruise on the forehead, instead of saying, did the baby roll off the changing table when you were changing the diaper, and maybe you just turned your head and went to grab a diaper, and did you hear the baby fall to the floor? Instead of that sort of history, we would ask that you just say, tell me what happened. How did you end up here today? And let the family give you the history instead of giving it to them. 3, again, if you leave with nothing else from this last hour, knowing that severity of injury and severity of risk are 2 totally different things. And do not fall into the trap that they are equal, because you will put your kids at risk for harm. And last but not least, for social workers who are on this call, for those of you who spend the time going through the psychosocial assessments with the family, it is probably the most important tool that we have as healthcare providers. Regardless of whether the child is being abused or not, regardless of whether you report this child as abuse or not, a psychosocial assessment adds lifelong value to your patients and to your ability to provide care for them. So, I would advocate that every child gets a psychosocial assessment. I'm sure the social workers out there are cringing at that thought, but it's just so valuable for your families and for you who provide care to these kids, especially when we have a child with an injury. A psychosocial assessment has to be a key piece of their evaluation. And with that, just will say a thank you to Carrie Baker, to Dr. Leiker, to Dr. Mary Clyde Pierce, and all of the participants of the TRAIN Collaborative. And there are just too many to name here, but people from all 6 children's hospitals, about 15 adult regional hospitals throughout the state, child welfare agencies, Casey family programs, several private or primary care pediatric practices around the state. There's been so many people that have contributed knowledge and insight to this topic. So I just want to say thank you to all of them. With that, I will ask if there are any questions and turn it back over to Olivia and Haley.
Thank you, Dr. Thackeray. Nothing has really popped up new. I know there was a comment in the chat kind of just agreeing with your approach about certain areas getting bad publicity and how much more would their cases be benefiting from standardized approaches like this. So just kind of wanted to highlight that comment. And as a reminder, if anybody has questions along the way, to enter them into the chat, and we can always check in at the breaks. And if anybody has anything to add now, feel free to add that to the chat.